to the show where we share the stories of the many who intersect with our healthcare system but are rarely heard from. My name is Kevin Poe, founder and editor of Kevin MD. Rate and review the show at kevinmd.com/rate. Subscribe at kevinmd.com/follow. Today in the show, we have Sujan Goju. He is a family and sports medicine physician. He co-wrote the Kevin MD article, How to Tackle the Physician Shortage. Sujan, welcome to the show.
Thank you for having me.
We'll get into the article in a little bit. First off, briefly share your story and journey to where you are today.
I come from a household where my father was a non-traditional medical student. And what I mean by that is he was 37, 38 when he went to medical school. And I was in the first grade when he started med school. And I got to see his journey going through medical school, going through residency, working in a rural community, and then starting his own private practice in a major metropolitan area such as San Antonio. And I'd seen that journey. It was in a journey that really appealed to me at the time. And at the time, I really enjoyed science as well. And so I thought medicine was a good fit. So I went to undergraduate school at the University of Texas at San Antonio. I went to medical school at the Virginia College of Osteopathic Medicine. And being a DO, we have more of a holistic approach to patient care. We really put an emphasis on musculoskeletal medicine. So right then and there, I knew I had an interest in sports medicine, and a route to take for that is family medicine. And so I wanted to come back home. So I went to UT Health Science Center in San Antonio, which was a great training program. And then I went on and I did a sports medicine fellowship at Texas A&M. And then I wanted to learn how to do more interventional spine procedures because so many people have back pain, neck pain, and so forth. And I did a pain fellowship at the Texas Pain Institute. And then I came down to a rural community such as the Rio Grande Valley. I didn't know what to expect down here. My wife is doing a residency down here, so that's what brought me down to the Rio Grande Valley. And the Rio Grande Valley, one of the most underserved communities in all of America. There is just not enough people to provide care for patients. And then you combine that with the problems that we have with the social determinants of health that some of these patients have, whether it's economic viability, whether it's their community viability, whether it's things with just not having access to clean water, roads, not having insurance. It's really hard to take care of patients here. And that was probably a little bit of my inspiration writing this article, because here in the Rio Grande Valley, I literally practice a lot of disciplines. I do family medicine, I work in an ER, I do sports medicine, I do interventional spine procedures, just because there's such a need down here for physicians to really provide good, comprehensive, evidence-based care to patients.
So before we get into the article, and you mentioned this, and I want this to be a context before we talk about your article, tell us a story that really paints a picture about how there is a lack of clinicians serving the Rio Grande Valley. Any stories that you could tell that really illustrates that point?
Yeah, absolutely. There was a moment where I was doing a shift in an emergency room, and this was obviously during the height of the COVID pandemic, probably the third or fourth wave. So it wasn't as bad, but we still had that wave. And a patient had come into me really fatigued and dehydrated. And he went and saw his primary care physician that week 3 times, and he still ended up in the ER. And this patient, the only thing that had been tested was a COVID test. It was only done 3 times. It was a rapid antigen done 3 times, and every single time it came negative. But there was no other lab tests that were done. There was no other inquiry into, does this patient really have COVID? Is there some other upper respiratory virus that's going on here? Is there some type of metabolic abnormality that's going on here? There was no further inquiry. There was just COVID test and let's discharge them. If it's not COVID, it's nothing else. And obviously, when I saw the patient, I looked at this patient. I was like, oh, I asked basic questions like, what's your medical history? Do you have a family history of diabetes? And that's one thing in the Rio Grande Valley. You have to ask because 1 in 3 people here have diabetes, and a lot of people here are not on medication. 1, medication is so expensive and people can't afford it. And 2, the health literacy here is just not as it is in other populations. And so a lot of times I really ask, what are your parents going through? What medical conditions do your parents have? How are they living right now? Did they die? What did they die from? I have to ask those tough questions. And so he had said, my mom, my dad, they all have diabetes. I don't have diabetes myself, is what he said, which kind of shocked me. And so basic test, you do a glucose level on him, and the glucometer couldn't even read it. Yeah. So right then and there, I knew this patient was in diabetic ketoacidosis, and I had to treat him for that in the emergency room. But I think what frustrated me about that case is a nurse practitioner saw this patient 3 times. There was no lack of supervision by an attending or a physician. And this is something that would not have been missed if there was a physician that was looking at it, because it was clear cut, very easy to pick up on this. And every basic primary care clinic can do a test a glucose level very quickly. And that to me was really frustrating, because the patient at the end of the day, he's like, well, I was treated well. I have nothing, no problems. There's nothing wrong. But I think when you look at the health system as a whole, you forget that this patient went to the clinic, to the primary care clinic 3 times. So there's 3 visits. There's insurance companies paying for 3 visits that didn't really diagnose anything. You also keep into account that the patient is wasting his time, because he had to waste 3 of his days and not feeling well for 1 week. So there's an economic strain on that family. But not only that, but it puts an economic strain on his job, because they don't have an employee. And then now he comes to an ER, and now he's being treated for DKA, which that bill at the end of the day is going to be astronomical. And now that patient is going to be stuck with that bill. So I think that is what frustrates me with kind of this healthcare system, especially with unsupervised mid-levels, is I think there is a lot that's being missed. And I think we're starting to have studies that really show some of this that's coming out.
All right, so let's talk about some of the approaches going forward. You wrote about that in your Kevin MD article that you co-wrote, How to Tackle the Physician Shortage. For those who didn't get a chance to read your article, just walk my audience through it.
The one big thing that really we really have to understand is we are creating far more medical schools, and the combination of the fact that we have a lot of foreign medical schools as well, where we have people applying to a limited amount of residency slots. And I think the one big thing that we're starting to notice in American medical schools is we're seeing a lot more medical graduates go unmatched. That number is increasing every year. In 2021, that was about 10%. So that's about 9,000 graduates. And so in 2021, Congress tried to rectify this issue by expanding the residency programs, but they only did 200 more slots for 5 years. And so it's a step in the right direction, but it's nowhere near the 9,000 that we probably need. And to be quite frank with you, we could even go above and beyond 9,000 because we have so many foreign medical graduates that really seek a license or a training program here in the United States. And so I think that's the one big step we really need to do, is start to expand these residency programs, get more programs so we can get people here. I think the other thing that I mentioned in my article is I think we really got to capitalize on the non-practicing workforce. So if you look at America, you read these stories in the New York Times, or you read these stories in the Chicago Tribune, that you often see an international practicing medical graduate that's driving a taxi, or he's working at a gas station, and he was a doctor in another country. And you can't say that we can't tap into that talent, because that talent would be very useful in rural America right now. It would have been very useful during the height of the pandemic if we could find a way to get them into this workforce to help their communities or another community that they want to be part of. And in one thing that we really do have that was hugely successful a long time ago was waiver programs for foreign medical graduates to go practice in rural and underserved communities. There's something called a Conrad 30 waiver. And right now there's only 30 such waivers in every state. And in my community, I know with the health system I work for, we utilize that waiver for 1 or 2 specialties that are very difficult to get here in the Rio Grande Valley. I give you an example, like here in the Rio Grande Valley, it's very tough to see a rheumatologist. We've been trying to recruit for one for many years, and we've just not been successful. So one thing that's really helpful is that we tap into using one of our waivers that we do have to get a physician to come to this community. And then my system will sponsor their visa so they can ultimately practice here. And I think it's hugely beneficial to communities such as myself, because that would give us access to a rheumatologist. But not only that, we're just one community. There's so many other communities here in America that are like that. I think the other thing is obviously licensure. Everyone has written about this. Everyone has talked about this. Is in Texas, for example, I'm only licensed in Texas. So I can't really provide care in other states unless I get that license. And it's so burdensome and expensive to try to get licensures and maintain them in so many other states. And that makes it a challenge if you're trying to do telemedicine. That makes it a challenge when there's other hospital systems that really need physicians or other type of non-physicians to really provide care. And so if we can ease that, I think that would be very beneficial. One thing that I think that we really also need to keep in mind, and I think you've noticed this probably as well, is during the height of the pandemic, a lot of physician practices shut down. About 8 to 10% shut down. The other thing that's very noticeable that happened during this pandemic was a lot of physicians that were thinking about retirement, they retired early. They're like, I don't want to keep up with this. I'm getting burnt out. And one of the things that's really causing burnout is really electronic medical records. EMR is very painful and it's just highly inefficient. And I look at myself when I go see a patient, I'm oftentimes more stressed out about documentation, about prior authorizations, about other forms that I have to fill out, rather than just spending time with my patient, getting to know them, talking to them, and so forth. And I think sometimes I feel like I'm a secretary more than I'm a physician, just because of how much documentation I have to do. And my job doing sports medicine is oftentimes I have to get an x-ray. Oftentimes I have to look at the x-ray. Oftentimes I have to make an assessment on that, tell the patient, figure out what's going on with the patient, and then decide, do I need to cast them? Do I need to do an intervention and so forth? And then do that. And I have 3 or 4 other patients waiting. But then in the meantime, I have to document that.
Sure.
And it's an impossible task for physicians to really do without getting burnt out. And EHR has got to be optimized to prevent burnout in some shape or form. And so those are some of the things that I think are very important. And at the end of my article, I really try to go into the solution. Like, what do we do about this? Physicians are really uniquely positioned, as we've seen in this pandemic.
Yeah.
We're a trusted messenger. We are a physician. We play a good role in hospital systems and being administrators. But I think the way we really need to move forward to really get policy change, because we're really not seeing it with their medical organizations, is really we need to get physicians in political office. You know, the only way change is possible in the healthcare system, and we're seeing this with the overturning of Roe, whether it's physician legislatures really enabling non-physician providers to provide care, whether it's really Medicaid expansion, all of these problems that we do have in healthcare, they're actually political problems. They're not something that I feel like the AFP, the AMA, other big medical organizations can really solve on their own. And one thing that I'm part of Doctors in Politics, which is we're a political action committee, which are really trying to support doctors to run for office so we can solve these problems because they're political at the end of the day.
So you mentioned a variety of issues that's preventing enough clinicians from practicing. What's some of the lowest hanging fruit that are out there? Because some of the solutions that you mentioned, getting doctors elected to political office, the effects of that isn't going to be felt for years to come. Any low hanging fruit that can address some of the problems that you mentioned that could provide more immediate response?
Yeah, I think the two things are there is really, I think they're low hanging fruit, but obviously with this political environment, it's difficult to pass anything. But I obviously think expanding residency programs is one, because that would get more doctors in the community. But I also think that another thing, which I think would be really get good bipartisan support, is really expand the Conrad 30 waiver program. There's 30 waivers available for each state. Let's bump that up. Let's get it to 50. Let's get it to 75 or whatnot. Because there are some just communities down here in Texas, especially in my community, we cannot get certain specialists that we really need to provide care. And I think that would help patients a lot, because if you need highly specialized care, patients in the Valley where I live, they have to go to San Antonio, they have to go to Houston. Well, that's like a 4 or 6 hour drive.
Sure.
And I think is a very low hanging fruit, low hanging ask that could get bipartisan support.
Now, what are some of the obstacles that's preventing an initiative like that from moving forward?
I think we need more people that are knowledgeable in healthcare in political office that understand these problems. I think that would be very beneficial. I don't think we have nearly as many. I think the last political cycle, we had 17 physicians when you combine the Congress and Senate. I don't think that's nearly enough. I think getting more people knowledgeable about healthcare would be beneficial. And a lot of these are just the gridlock that we have, unfortunately, at state legislatures, in the Congress and Senate. It's hard to get anything passed in healthcare. And some of these do require spending money or moving around money in certain ways. But at the end of the day, the cost savings that you get is astronomical. And we should be looking at cost savings. And some of these are highly beneficial for that.
And my final question, what are some of your take-home messages that you want to leave with the Kevin and the audience?
We as physicians, one, I think we serve as leaders in our community. And I think being a leader means really being involved in the political cycle, getting involved in local races, educating people, be part of supervisory boards, advisory boards of your hospital system. I think leadership is where advocacy can be done. And so I think that's very important. I think too, as physicians, if you have the avenue, run for school board, run for a state legislature seat. You can still keep your job as a state legislator in a lot of states and be practicing medicine. There's many physicians that are actually out there doing that.
Sujan, thank you so much for sharing your time and insight. Thanks again for being on the show.
Yeah, thank you so much, Kevin. Really appreciate it.